Good morning. Just getting us all sorted. There it goes. Okay, let's get everyone else moving here. Just getting the lives going here. There we go. All right, here we go. Let's do this. So, perfect. Okay, we're good to go. Let's get this guy started. So, welcome to the breakdown of our femur fracture patient. It was a fairly interesting patient, if I must say. Perfect. Okay, so as far as this femur fracture patient goes, let's talk about this guy and kind of have a quick discussion about it. But before we kind of get started, everyone's kind of just piling in here because we just got started. So before we really get started, why don't you guys let me know where you guys are from? Go ahead, let me know where you guys are watching from before we get started here. I'd love to hear the answer to that. So go ahead, put that in the comments. Let's see where you guys are watching from, and then we're going to get started in about 2 minutes here after we kind of get the introductions out of the way. Where are you guys watching from? California, South Carolina, Colorado, Edmonton, right on. Whereabouts are you all? Sherwood Park, England. Good to see you. Staying in Saskatoon, cool. From Germany, brought you to Saskatoon. Scotland, right on. Well, that's fantastic. I'm glad. It's always awesome to kind of see where you guys are all from and where you're watching from. Florida, Grand Prairie. I was just in Grand Prairie 3 times last week, or 2 weeks ago, I guess now. Perfect. So let's talk about this this femur fracture patient, and well, don't worry, we'll make sure that you guys get caught up on the on that patient of kind of what's going on with them. We'll review the case that we put up this morning, and then we'll get started. But first off, before I do that, I want to let you guys know of something, is that Mastermatics is going to be at EMS World this year down in Orlando, Florida. It's going to be not next week, but the week after that. And we have organized a Mastermatics Fan Party. We've got a private venue for our Mastermatics fans that want to come and have a few drinks with us, enjoy some conversation, and have a fun night with us. So we are going to be there. EMS World is going to be on the Thursday night of EMS World. That's October 13th in Orlando. We're going to be doing a Mastermatics fan party. So how do you get to part of that fan party? Well, we're going to be handing out the tickets to that party, the information to that party at our booth. We have a big booth. We're crazy enough to bring our ambulance all the way down from Canada down there, and we are going to be there handing out tickets to this fan party, so that way you guys can attend. It's going to be a great time that you guys can enjoy some conversation with us, and as well enjoy the entertainment that we've all set up for you. So that's pretty exciting. And if you want this and you want to be part of the fan party, please do not hesitate to reach out to us and let us know, and we'll get you situated. But again, we're going to be handing out tickets at our booth at EMS World. Okay, without further ado, let's start the case. So you're dispatched to a 36-year-old male patient who was struck by a car. The car struck him in the left leg, which forced him up and over the windshield. The patient is alert and orientated and denies hitting his head at all. He says he has had a lot of pain in his left leg and wrist. Upon assessment, we find the wrist to have obvious swelling and was very painful on palpation. The patient has extreme pain on palpation to the left thigh. He exposed the area to find a fractured bone protruding through the skin, but there's minimal amount of blood currently. Pelvis is stable on palpation. He denies any pain when you palpate it as well. Vitals here. Skin is pink, level of consciousness is alert, eyes are pearl, breasts are here, but I'll just flip over here. This is what you get. Okay, heart rate is 132, SpO2 97, your CO2 is 35, respirate is 22, and your blood pressure is here, 132 on 83. Okay, so before we kind of dig into this, what is your first impression of this patient? Is there anything that's jumping out at you with this patient? What's your primary concern here before we kind of talk about the treatment that we can do for this patient? Go ahead, put that in the comments. Let me know what your thoughts are of what you're concerned about with this patient. What do you think? What are your concerns with this patient? What happened to the patient? He was hit by a car in his left leg. And you have protruding femur bone out of the body. Standpoint, sorry, just knocked you over. From a medical standpoint, this patient is doing okay right now. Okay, so anytime that I'm coming up to a patient like this, I'm like, okay, what are some things that I need to be watching out for? First off, just because he says he didn't hit his head doesn't mean that it didn't happen. He could be confused, those kind of things. And so just because he said he didn't hit his head doesn't mean that we don't do an assessment. Okay, it doesn't mean that we don't do an assessment. So we want to make sure that we are doing a neurological assessment, confirming that there is no concern or a low risk of head injury. That's the first thing that we're going to do to make sure that we're not going down that path. Okay, then we're going to continue down the body in our trauma assessment. Just because there is an obvious injury to the leg doesn't mean that we shouldn't be going back and doing a full assessment of the body. That's a very important thing to do, so that way we don't miss anything and walk ourselves into a distracting injury with the leg when they all of a sudden have, you know, a flail segment or some sort of rib fracture or tension pneumo, those kind of things that can be more deadly. But we were so focused on one thing that we didn't do an assessment of for the other things. Okay, so that's the first thing that I'd say here. So that's what I'm thinking in these types of situations. Like, okay, I got the leg, the vitals are stable. Let's go and make sure we didn't miss anything. That's kind of what's going on in my head in these types of situations. So do your assessment, go down the body. Now he's hitting his head. Let's do a neuro assessment to make sure. Okay, then he says that he has a lot of pain in his left leg. Okay, we already know what's going on there, and his left wrist. So assess the left wrist. Make sure that we don't have any injuries or concerns there. So when you're assessing this left wrist, what are some things that we want to check to make sure that we don't have to intervene with this injury? What are some things that we need to check to make sure that we don't have to intervene? Go ahead and put that in the comments. Good. You guys are thinking the pulse? I agree. the pulse is going to be a very important thing with this particular patient. Okay, checking the pulse, making sure that we are making sure that this patient is still has those distal pulses, especially in that left wrist that he's saying that he has quite a bit of pain with, making sure that we don't have to intervene with that. If he has a pulse of that wrist and he has good cap refill, so if you can't check a pulse because his wrist is in so much pain, checking the cap refill on the fingers to confirm that they have good cap refill is another way that we can confirm that we have good perfusion distally. You can also take your SpO2 monitor. SpO2 monitor on the finger or on the fingers of that hand to confirm that we have good saturations distally of the injury. Make sure that we don't have any circulatory in that wrist. Okay. Now we've done the rest of the body and we find that the pelvis is stable. That's good news. That means that we can intervene with this femur a little bit more. And we're going to talk about that in a sec here. Next thing that we're going to go into is look at this leg. Okay. Again, with this leg, okay, we have the bone that's protruding out. Okay. So you have essentially, if this was your patient here, this guy, okay, essentially what that is saying is that this bone here, this position, this part of the bone is typically in place. Okay. Obviously it's still fixed to the pelvis itself at the femur head. And so if we have a fracture midline, what happens is the muscles will contract. And when they contract, this part of the bone, the distal portion of the diaphysis, will actually shift upwards. And that's what's protruding out of the skin. Okay. It's very rare to have both sides of the bone just protruding out of the skin. It's usually just one side of the bone that's protruding out. And that is because of the shortening of those muscles, the contraction of those muscles, that's causing the shortening and pulling of that bone up out of the skin. Okay, so that's what's going on with this particular patient. So we have a protrusion, we have an open fracture that we need to deal with. Okay, so when it comes to these types of injuries, what is really important, there was something on TikTok that when I posted this video and posted this class, there was someone that asked a very intelligent question about this. And what was it? What are some things that you're going to want to do to treat this patient? What are some things you want to do to treat this patient? Or I guess confirm the severity of the injury in the leg. That's kind of what I'm getting at. What are some things that you want to confirm for the severity of the injury in this leg? We did it in the wrist. We want to do it again here. What are some things? Okay, shortening. And so which way does a femur typically shorten? It shortens externally because the muscles are going to pull that femur outwards. Okay, so the foot is often externally rotated in a femur fracture. Okay, a midline femur fracture. Head of the femur fracture can be both because usually the pelvis is involved in that, but a midline femur fracture often will pull outwards or externally rotate and shorten. Good. And that's all due to muscle shortenings and muscle tightenings. Okay, and just the direction of travel of a lot of those muscles and the gluteus maximus or gluteus muscles as well. Okay, so that is for sure. Next thing that we're going to do is confirm circulation in that leg. Okay, in a femur fracture, when we have shortening of those muscles, and then we also have that that open femur fracture type of look, that's something that we need to be really concerned about. Okay, and so with this particular patient, what can happen in those situations is that the vessels can actually kink. You only have one main vessel that's feeding that leg, that the femoral artery that splits into the popliteal artery behind the knee. But when we have that shortening of the muscles and that leg shortens up and the bone starts to collapse or kind of compound out, basically what happens, those vessels, a lot of people think that typically it's going to shear or rip apart that vessel of the femur. That's not really the case. That's not why we lose distal circulation. Often what happens is that shortening is going to kind of bend or kind of weaken the anchoring of that vessel, and it's going to kink like so. So really it's not a lot of the time where those bone ends just kind of puncture and rip apart that femoral artery. It's more of a kink like so. Okay, and so that is something that we need to look at here, because that's going to probably help us determine what we're going to do next. Now, I mentioned that this patient has circulation in the leg, okay, in the distal part of the leg. There's a few things that you can do. You can check the popliteal artery, you can check the dorsalis pedis pulse, or the posterior tibialis pulses, all in the distal portions, like to confirm that we have good pulsatile circulation in that area. Another thing that you can do is you can also take your SpO2 monitor, switch it to a kind of the Band-Aid version, okay, that stretchy version, and put it on the toes to confirm that you have distal circulation. You can use that SpO2 monitor for more than one thing. We already know this guy's ventilating and he's got good saturations in the hands, okay, that's where you put the SpO2 monitor now. Then just, if you know that and this patient hasn't deteriorated anything, then why don't we just put it on his toe so we can monitor the circulation of that foot? Because it doesn't mean, just because we had it at one point doesn't mean it's going to stay like that. Okay, this patient could deteriorate further, so putting an SpO2 monitor on him, it's not a bad idea on that foot. Okay, so we have circulation in that leg. Now that brings me to the question of, should we use a traction splint in this patient? Why or why not? Go ahead, put that in the comments. We have circulation in the leg. The patient is in extreme amount of pain. Should we use a traction splint in order to bring that leg more into midline? Go ahead and put that in the comments. I'm interested to know what your answer is. So I see a lot of no's as far as it being an open fracture. Kev's thinking yes. A few people are saying no. So the world of femur fractures and the treatment of them is very split down on this. Okay. Most literature and most protocols, which you need to follow in these situations, do not cowboy up on this one. Okay. Most protocols and most literature is saying, because it's an open femur fracture, that it is contraindicated to use a traction splint. Most. Okay. However, ITLS has come up with a statement, because there's not a lot of studies that have shown kind of the concerns of doing this. The biggest concern in theory is that if we have an open fracture, there's a concern that if we bring that, if we start to use a traction splint and pull that ends of the bone that are exposed to the environment and have exposed to disease, that if we bring that back into the body, there's a higher risk of disease. That is totally a possible thing. But I guess we're looking at the benefits and the risks. And truly, there just isn't enough studies on this and enough information on this to say that our concern with infection is as big of a risk as we think it is. And so ITLS has come out basically saying that in an open femur fracture, it is a benefit to a patient to use a traction splint if you have a very long transport to the hospital, or you're in a rural or remote area, because of the duration of time it's going to take to get to the hospital. That's basically what they've said. They haven't said anything about we should be using this on a routine basis. We just don't have enough information to suggest that that is a benefit. Okay, so when it comes to the answer to that question, and it's probably one of your favorite questions or answers, is it depends on what your protocols say. And also at this particular point, we just don't know enough about information to suggest using a traction splint, whether that's a high risk situation in an open femur fracture. A lot of protocols are switching to, why not? Because this patient is getting antibiotics anyways. Why not use it? Because the risk of infection is low if we already are going to be using antibiotics in this patient anyways. Okay, so there's a lot of controversy with this, a lot of discussions. As far as the open femur fractures that I have seen traction splints used on them. I've also seen physicians avoid them for transport to major hospitals for surgery. So I've seen both sides of this, and as well, I've seen it on both sides in the last 2-3 years. Okay, so we're pretty split as far as what we should do with an open femur fracture like this and using a traction splint. Okay, so should we use it? It really depends on your protocols. Now, how do we use it? Very simply put, is that you're going to have your saddle. Now, depending on which one you're using, but most have a saddle plate placement that kind of sits right into here, kind of in the groin. And what it's going to do, because you obviously have a fracture here in the femur, okay, then we have basically a strap on the ankle, and then we kind of use the pelvis as kind of like a push point. Okay, so it kind of sits in the pelvis, and then we basically pull on this strap that's on the ankle and ultimately pull the bone back into a more midline position, relieving a lot of the pressure and pain this patient is having. Okay, so that's how a femur or a traction splint works. Now, there's a few things you need to know about traction splints. Is that one, it only gets used in midline femur fractures. Okay, midline femur fractures. It doesn't get used for patients that have bone end fractures at both sides of this. So even proximal and distal portions of the femur. It needs to be midline. One hand width away, okay, from a joint is usually what we're using at the basic level to determine if this is a diaphysis or a midline fracture. Okay, so that's the first thing. Next thing is that we are only using 10% body weight of this patient, okay, up to 15 pounds, okay, up to 15 pounds on that traction splint. So it's used for midline fractures and only up to 15 pounds or 10% of the patient's body weight, whichever one comes first. And the next thing is that you cannot have any injury to the knee, you cannot have any injury to the tibia, and you can't have any injury to the ankle, because you need all of these points to be intact in order to use the traction splint without causing further damage to other parts of the body. Okay, so it needs to be an isolated mid-shaft femur fracture in order for this to be a patient that's a candidate for traction splints. Okay, same goes for the pelvis. You cannot have a patient that has a pelvic fracture and trying to shove a traction splint up into the pelvis for leverage. 15 pounds of traction into the pelvis is not a benefit for these patients when they have a pelvic fracture. So that's an important thing to determine if this person has a pelvic fracture. Katie's asking, so how far away was ITL staying? They did not state a time. They basically said rule setting or a isolated settings where time to hospital was a long period of time. They did not state a specific time with that. Great question. Okay, so that's how you apply a traction splint. Okay, and using it in order to do this. So all it's really doing is it's basically trying to bring that bone that's fractured into a more midline position. There's a few things that it's going to do when it does that. So let's talk about that real quick. So out of curiosity for you guys, I want to know what you've been told of how much blood you can lose with a femur fracture. So if we had a major bleed, this patient doesn't seem they're at risk right now for, they have a tachycardia, that could be pain, stress. It could also be a compensated shock. We don't know at this point, but that being said, how much blood can a patient lose into the compartments of this leg? How much blood can they lose? Would paramedics administer antibiotics in the field? It's possible. One, it really depends on the protocols. We have antibiotics that we use, but a lot of urban settings would not, so they would be given at the hospital. But yes, is it possible that we can? Yes, there are places that we do. Okay, so you guys are thinking 1 to 2 liters, 1.5, 3 to 4 liters, 2 liters, 1.5. 2,000 mils. So really when it comes to these, the compartments of the femur can hold up to something like 3,000 milliliters. But typically you're going to be losing somewhere around the range. If there was an active bleed going on, is that you can lose up to about 1.5 liters of blood into the compartments around this bone. Okay, that number goes up because if you have a destabilizing or open femur fracture. Now, the reason why is that when you have a femur fracture, okay, then what's going to happen is that that allows for displacement of the femur. So you basically have your femur that's doing this. And so your muscles shorten and your skin is no longer taut. Okay, so, or taut, whatever it is. So when that occurs, it means that more blood can pool in there, because when your skin isn't taut, okay, and your muscles are now shortened, it allows for those compartments to expand like a balloon. Okay, so that means that there's not nearly as much tamponade when that bleeding occurs, because once that compartment fills up, when you have tamponade, then you're going to have pressure on those vessels and the bleeding is going to start to slow. But in a displaced femur fracture where the muscles are shortened and the skin is not tight, then it allows for less ability to create tamponade on those bleeds, and the slowing of bleeding will not slow nearly as fast. So it allows for more accumulation of blood in that area, which leads me back to the question of, should we be using traction splints in open femur fractures? My thought is in these types of situations, when there's evidence of significant blood loss, I think that yes, there's more of a benefit than a risk, because by using a traction splint and we're trying to make the bone come more midline and allow for those muscles to stretch out and allow for the skin to become more tight, it allows for an increased amount of tamponade in that area in order to slow that bleed. Okay, so that's my thought with it. But again, showing evidence of blood loss or significant blood loss. Another reason that we may do it is that if we had circulation compromise. So if this patient, if we put the SpO2 monitor on the toe, we realize that there's no SpO2, there's no distal pulsatile flow of blood, we can't find pulses, you can see obvious changing in color in the leg or the lower leg or the distal portions from the fracture, then this is an indication that that vessel is either broken or more likely kinked. Okay, and so bringing the bone more midline would pull that vessel from being kinked. Okay, basically alleviating its garden hose type of kink type of situation, where it would relieve that and allow for restoration of blood flow. Okay, but again, this is all when it comes down to your protocols. But if you recognize these things, like they have poor circulation, okay, or they have evidence of blood loss, okay, internal blood loss into those compartments, calling your medical director, like, hey, this is the patient that I got. I know that we don't use traction splints for open femur fractures, but I think this patient would really benefit for these reasons. There is nothing wrong with making that phone call and asking for permission. And I think that you can make a pretty strong case for it. So that's just my thought on these types of injuries. Okay, so yes, this patient is at risk for a significant amount of blood loss, and we need to be paying attention to that. Now, with the vital signs that we have, we're doing okay. Okay, when it comes to this heart rate, a lot of people are like, oh, this is probably from the pain, this is probably from the stress, this is probably not a blood loss or heart rate. My advice to you in those two situations, that this is compensated shock until proven otherwise. Okay, that's how you should be thinking about it in your head. Yeah, is it likely that it's probably from the pain, that it's probably from the stress and the emotional stress that's happened in this? They're scared, they're in pain. Is it probably why that's happening? Yes, but there is a chance that this is a compensated shock due to blood loss in that compartment. And we don't know that. So as far as your brain should be thinking is that this heart rate is compensated shock until proven otherwise. I think that's a pretty fair statement. Okay, so what are we going to do for this patient? Well, there's not a ton that we can do other than potentially using that traction splint if it's warranted in this situation. We're going to use if we're not going to use a traction splint, we're going to cover that wound with sterile gauze, try and cover that area over. That way the bone ends don't dry out. Okay, and wet sterile gauze, that's kind of what bones are wet. Ironically, it's kind of a weird one to think about, but bones are wet. And so we want to use wet sterile gauze in order to limit the bones from drying out. That way we don't have to do as much of a, the surgery that itself is going to be nearly as complicated, or hopefully nearly as complicated. The next thing that we're going to do is treat this dude's pain. Okay. Treat this guy's pain. So what would you use in these situations? I'm curious, paramedics here, what have you noticed that works really well for musculoskeletal pain? And treating that in order to relieve some of that pain. Go ahead, put that in the comments. What's your go-to for musculoskeletal pain? Is it fentanyl? Is it ketamine? Is it a combination of the two? Is it fentanyl with a little bit of Versed? Is it morphine? What is it? Is it Entonox? What are your thoughts? Entonox, morphine. I'm kind of in that. I'm usually kind of if the patient is not having significant bleeds, or I don't have any, like this patient is not deteriorating, they don't have a hypotension or anything like that, I will often use, some fentanyl with a small amount of Versed. And that is, again, if it's not in your protocols, it's not in your protocols, you can't use it. Ketamine also works really well for these types of situations. I like it for this kind of situation for pain management. My usual go-to in these types of musculoskeletal injuries is some fentanyl with a little bit of Versed, like 1 or 2 of Versed kind of. And what that does is it allows for a relaxation of those muscles, and maybe decreases some of that pain on top of what the fentanyl is going to do. So kind of essentially treating the source of why that pain is there, the shortening of those muscles. But again, follow your protocols, but that's what I like to use for that particular reason. I had a paramedic mentor that used it and it worked great. And so I have picked up that tip and continue to use it. And it works great for me. But again, follow your protocols of what you're allowed to do. A lot of protocols will not allow you to use Versed for this type of pain management situation, but some still do. Okay, so that is what you're going to do for this patient and get them to a hospital that can manage a complicated femur fracture. Okay, so that's what I have for you today. Any questions that you guys have? Go ahead, throw your questions in the comments. Can they bleed out in the thigh? It is possible. I mean, like if we can lose up to 1.5 liters, that's a 30-year blood supply. Can they bleed out completely? There's some literature that says that you can bleed up to 3,000 milliliters into those compartments if they're unstable, meaning that they are not able to provide tamponade. So is it possible? Yes. Is it likely? No, but it is possible. Sure. But any questions? Any other questions? Near vascular check, reducing. Yeah, there you go. Perfect. How will this coach me? That is a good question. I likely, whatever the Nancy Caroline says as far as traction splints, I believe they're on the side of not doing them for open femur fractures. It's very controversial. Like there's a lot of people on both sides of the fence saying do it and do not do it. I believe the Nancy Caroline is on the side right now of don't do it for open femur fractures, but I could be corrected on that. You'd have to double check, but that would be my advice for this. Okay, so I didn't see any other questions, so I just want to remind you again, while you're still here, we are doing a Mastermatics Fan Party at EMS World on the October 13th in Orlando. And in order to get the details of that, the invite of that, you either have to email me, jeff@mastermatics.com, in order to get a ticket to come. It's a private party. We have a private venue for you guys, and to come and talk with us, hang out with our team, hang out with Mike and Ben and myself and our back end team. You can kind of get into see everyone and get to know everyone. That's what we're going to be doing here at EMS World. So we're going to have the EMS Mastermatics Fan Party for you guys. We have a booth at EMS World, so come up, say hi, and if you're interested in coming to the party, ask for that, and we will give you the tickets for that to get into the private venue. So we would love to see you there if you're coming to EMS World and coming to the party, to the private party, the fan party itself. So this is the first time we've ever done this, so we'll see how it goes. I know it's going to be a lot of fun, but yeah, that's something that we're throwing for you guys as our fans that are able to make it to EMS World this year. So thanks so much for joining me today. And I'm just going to do a quick little run around, make sure. If there's a TXA for suspicion of bleed, absolutely, Jay. Just our internship. Biggest things, Chad, with your internship is to really just focus on your focus on kind of getting through your system, your system's assessments, making sure that that's appropriate, and like doing it consistently, not just doing, you know, focus assessments on respiratory patients and focus assessments only on cardiac patients. You want to make sure you're doing your full head to toe on every single patient, especially an internship, because this is where you're most likely to miss things and your preceptor will notice it. So that'd be my biggest thing, is that find your consistency of your assessment when you're doing this. This is the first and most foundational thing you can do for your internship, Chad. Okay. All right. I'll let you go for now. Again, if you think of anything after the fact, always feel free to reach out to us about these femur fracture patients. We'd love to hear from you and answer your questions. So don't hesitate to do that. But that being said, I will leave you at that, and we will talk to you next week. Bye for now. Misha, we actually just started a EMT mastery, which is part of Mastermatics. So I teach it. And so you can jump in there. Basically anything that's in your textbook, you can jump in.